Welcome back, listeners. This week we actually have a throwback. This will be an episode we released in December 2024, and it was the top trials of 2024. I think they will still be relevant, even though this is coming out in July 2025. Just a quick reminder for any listeners who are trainees, if you want to get involved with the rounds table or trial files, send me an email at fralickmpf@gmail.com. All right, and now to the throwback of the top trials of 2024. Hope you enjoy. This is the rounds table. All right, welcome back, Rounds Table listeners. We are going to be ending the year with a top 5 of 2024 in 23 minutes or something like that. Before we keep going, take a second, pause, write us a review on Spotify, Apple Podcasts, wherever you listen. Huge help, much appreciated. All right, enough of the annoying ask. Let's jump in. John, I'm going to go first. And the first article up is Finerenone and heart failure with mildly reduced or preserved ejection fraction, published in the New England in 2024.
All right, great. What was the research question here?
Can Finerenone reduce morbidity and mortality for adults with preserved ejection fraction heart failure?
Okay, what was the study design?
So industry-funded, double-blind, placebo-controlled trial. In the spirit of rapid fire, we'll keep it pretty short and sweet, but they included adults with heart failure an ejection fraction of 40% and up. The inclusion criteria in a bit more detail. So minimum age of 40, NYHA of 2 to 4, and you had to have an elevated BNP. The key exclusion criteria were GFR less than 25, potassium above 5, a recent heart attack, TIA or CABG in the past 90 days. And another exclusion is use of CYP3A4 inhibitors, drugs like clarithromycin, intervention Finerenone, comparator placebo, and the primary outcome was worsening heart failure events and death from cardiovascular events.
Okay, who was included in the study?
So 6,000 patients were randomized, average age of 72, 45% were female, nearly 80% were white. The average GFR was 60, average ejection fraction 52%, 25% had a prior MI, and 14% were on an SGLT2 at baseline, and 3% on a GLP-1.
Cool. And what did they find?
So the primary outcome of worsening heart failure events and death from cardiovascular events occurred in 36% of those who received Finerenone and 42% in the placebo group. So that was a 6% absolute risk reduction, which is pretty freaking impressive, a 26% relative risk reduction. And whenever you have a composite outcome, you want to know, well, what was it driven by? And in this case, primarily driven by a reduction in heart failure events.
6% absolute risk reduction is definitely impressive. Any major limitations with the study?
I mean, this was an impressive placebo-controlled double-blind trial. It's really hard to criticize. I think it's important to note that SGLT2 use was relatively rare. And of course, SGLT2s are now indicated for heart failure with preserved ejection fraction. It's unknown whether or not, the combination of both of these is better than just one of them.
Yeah, okay, fair. So what do you think? Drop spironolactone and add Finerenone? Is this practice changing for you?
Yeah, I typically don't give spironolactone unless the patient has reduced ejection fraction. But, some people might disagree with that approach. But for sure, this is a game changer of a trial. And once we can get better access to Finerenone in Ontario and Canada more broadly, I am certain to be prescribing it.
Okay, great.
All right, 1 down, 4 to go. John, what's up first from your end?
Let's talk about Tirzepatide for the treatment of OSA and obesity. This was by Malhotra et al., published in New England Journal of Medicine in October 2024.
Cool. And what was the research question?
They wanted to know, what is the safety and efficacy of Tirzepatide for treatment of adults with OSA and obesity?
Yeah, this seems like a no-brainer and a pretty smart research question. How did they design this study?
So this was the SURMOUNT-OSA, which was actually 2 different phase 3 randomized controlled trials that were both double-blind, placebo-controlled, and done at 60 sites across 9 countries. The general population was that patients had to have had moderate to severe OSA. That was defined by an AHI of greater than or equal to 15, and obesity, so a BMI of over 30. For trial 1, it included adults who were unable or unwilling to use CPAP, and for the second trial, it included adults who had already been using CPAP for at least 3 months. There were some important exclusion criteria, including if you had diabetes, as well if you had central or mixed sleep apnea, you were excluded. So for the randomization, it was 1-to-1 to either Tirzepatide or placebo given subcutaneously once weekly. All patients also received lifestyle counseling, as well as some other advice around physical activity. So the Tirzepatide dose was started at 2.5 milligrams and increased by 2.5 every 4 weeks until a max dose, which was around 10 or 15 milligrams. So AHI, which again is apnea-hypopnea index, was measured at baseline, week 20 and week 52, and sleep scores were scored centrally, and sleep studies were scored centrally. So the primary outcome here was change in AHI from baseline, and then there were multiple secondary outcomes, including some quality of life measures, and of course, weight change, which we'll talk about. This was an intention to treat analysis.
Cool. And what did the patients look like who are included?
So from 2022 to 2024, 469 participants were randomized to Tirzepatide or placebo. For trial 1, the mean age was 48, 67% were male, 66% were white, and the mean BMI was 39.1 with an average AHI of 51.5 events per hour. Trial 2 is similar, mean age 52, 72% male, 73% were white, BMI was 38.7 with a mean AHI of 49.5.
Yeah, I mean, that is very severe sleep apnea. Anyway, what did they find?
So for trial 1, they found that the change in AHI at week 52 was minus 25.3 events per hour for those using Tirzepatide compared with minus 5.3 events for those using placebo. That was an absolute difference of 20. For trial 2, the AHI was reduced by 29.3 events per hour in the Tirzepatide group versus minus 5.9 events in the placebo group. That was an absolute difference of 24. Now, as a reference, because I'm sure you want to know, the American Academy of Sleep Medicine defines a clinically significant threshold for the AHI as 15 or more points per hour. There was a bunch of those secondary outcomes. Unsurprisingly, those with Tirzepatide lost more weight. It was about 18 to 20% of their body weight versus 2% in the placebo group. They also found that patients had reduced severity in their disease to the point where some patients might no longer have been considered for CPAP therapy, and some of the quality of life measures also suggested improvement for those in the Tirzepatide group. Adverse event rates were kind of what you would expect, so GI symptoms were more common in those on Tirzepatide.
Yeah, I mean, this is an incredible medication, right? Like, patients are losing 20% of their body weight, and the number of apnea-hypopnea events was like cut in half with Tirzepatide. This really feels like a slam dunk, but what were the limitations?
Overall, also like a really well-designed study. You know, it's interesting. They did indicate that the statistical analysis was done by employees of the sponsor, which was Eli Lilly. And I don't know why you need to do that in this day and age. Just have like an independent person part of the study team. The drug company just makes it seem a little dirty, but nonetheless, I guess we also have to acknowledge that follow-up here was only up to a year. So what happens beyond that, we don't know.
Yeah, that's fair. This multi-billion-dollar drug company probably has like $10,000 kicking around to get somebody else to do the statistics. So, I mean, whether it's an Eli Lilly statistician or not, with numbers like that, you know, you don't even need a calculator. You need like crayons to show there's a big difference. But you're right. Come on, for the love of God, just get like somebody outside of your company doing your stats. Anyway, practice changing.
Yeah, I mean, Tirzepatide shows a clinically meaningful improvement in sleep apnea. And I think, you know, we're going to add this to another reason to use these medications. The caveat, of course, is that in Canada, the indication is only for diabetes at present, but hopefully that gets updated soon.
Yeah, that's just a reflection of our, what's a nice way to put it? Lackluster. No, that's too mean. Not so great healthcare system. Okay. Next up, staying in the ballpark of GLP-1. This was the effects of semaglutide on chronic kidney disease in patients with type 2 diabetes, also published in the New England Journal of Medicine.
All right. What was the question here?
For adults with diabetes and chronic kidney disease, does semaglutide slow the progression of said chronic kidney disease?
And how do they do this study?
So another industry-funded, double-blind, randomized trial, they included adults with type 2 diabetes, a GFR ranging from 25 to 75, depending on the degree of the proteinuria, defined using ACR. Key inclusion, A1C up to and less than 10%. They had to be on an ACE or an ARB. Main exclusion, recent MI, stroke in the past 60 days. They also excluded those on dialysis or those with severe heart failure, NYHA class 4. Intervention was semaglutide, up to a dose of 1 milligram weekly. As a reminder, the starting dose for semaglutide is 0.25 weekly. Comparator was placebo. And their primary outcome was a bit of somewhat ugly composite. So this was defined as major kidney disease events, a composite of the onset of kidney failure, such as dialysis, need for transplant, GFR less than 15, or a reduction in GFR by 50% from baseline, or death from kidney-related or cardiovascular causes.
Okay, and baseline characteristics, who was included in the study?
So 5,500 were screened, 3,500 were randomized, average age of 66, 30% were female, 65% were white, 25% Asian, and 5% black. Average A1C was 8%, average BMI of 32, average GFR of 46%. Only 15% were on SGLT2s, and 95% were on an ACE or an ARB.
Okay, what did they find?
For the primary outcome of major kidney disease events, this occurred in 19% in the semaglutide group and 23% in the placebo group. Said differently, that's a 4% absolute risk reduction, so a number needed to treat of 25 some odd people over 2 years, and on a relative scale, 25% relative risk reduction. So again, whenever there's a composite, you want to know, well, what drove this finding? And primarily, it was driven by this improvement. Said differently, less patients had more than a 50% reduction in their GFR. Maybe said simpler, patients in the semaglutide group had a better GFR by the end of the trial. Serious adverse events were less common in the semaglutide group. That's an important take-home point. And there were, however, more GI side effects with semaglutide.
What were some of the limitations here?
Yeah, we can quibble for sure how clinically relevant is this primary outcome, especially when it's driven by a number, the creatinine. However, that's our go-to trial for the vast majority of these large clinical trials assessing medications and their effect on kidney disease progression. Another limitation is that, again, SGLT2 use was rare, and we know that SGLT2s are very much indicated for most adults with diabetes, especially if you have chronic kidney disease. So it begs the question, well, if 100% were on an SGLT2, would we still have seen this degree of improvement? Another limitation is that semaglutide is very expensive.
The optimist in me would hope that, hey, maybe if they were on an SGLT2 as well, there would be an even more improved outcomes from a renal perspective. But maybe that's a little too optimistic. What do you think?
No, I think that very much could be the case. And semaglutide, one of its real benefits over SGLT2s is a much better improvement in weight as well as systolic blood pressure. And I suspect by improving both of those, you probably will have additional renal benefits, but I'm of course totally speculating.
Yeah, I mean, that certainly makes sense. Okay, what's the takeaway? Is this practice changing?
Yeah, for me, it's practice affirming. It's pretty hard for me to not prescribe semaglutide these days to patients who I'm caring for with diabetes. This is just like a whole other reason for why we should be giving this medication. And I think as internists, we do an atrocious job of starting a drug like semaglutide on discharge for patients. And that's something I think we should and can be a lot better at.
Yeah, that makes a lot of sense.
All right, John, trial number 4, back to you. What's up next?
So this time, same drug, different indication. Tirzepatide for metabolic dysfunction associated steatohepatitis with liver fibrosis. This was Lumba et al., published in New England Journal of Medicine, June 2024.
All right, and what was the research question?
They wanted to know, does tirzepatide lead to resolution of steatohepatitis without worsening fibrosis?
Yeah, this really feels like a smart question. Anyway, what was the study design?
This was a phase 2 multi-center double-blind randomized placebo-controlled trial conducted in 130 sites in 10 countries. The trial was designed and data collection and data analysis was performed by Eli Lilly, the sponsor. So the population, they were adults 18 to 80 with a mean BMI between 27 and 50 with or without diabetes. They had to have biopsy-confirmed MASH with either stage 2 or stage 3 fibrosis and active disease activity based on the NAFLD activity score. Liver biopsy was done at the time of screening or no more than 6 months before screening. There were a number of exclusion criteria. So if you had chronic liver disease for any other reason, if you had existing cirrhosis or other hepatic decompensation, if you had uncontrolled diabetes, which they defined as an A1C of greater than 9.5, and if you were on a GLP-1 medication already. So for the intervention, it was 1:1 to 1:1 randomization of Tirzepatide at different doses versus placebo. So 5 milligrams, 10 milligrams, 15 milligrams, or placebo. Patients were treated with weekly dosing for 52 weeks. The starting dose was 2.5 milligrams, and that was increased by 2.5 every 4 weeks until they were at the target. And they also got, the lifestyle nutrition counseling. A liver biopsy was done at the end of 52 weeks, and for that comparison, again, it was placebo-controlled. So the primary outcome was defined as resolution of MASH without worsening fibrosis, defined as no increase in the fibrosis stage on that repeat biopsy at 52 weeks. MASH resolution was defined by the degree of steatohepatitis and inflammation. There were a number of secondary outcomes that they also looked at.
Yeah, this is impressive. I wondered, why on earth are they biopsying patients again 52 weeks later? No patient is asking me, hey doc, can you put a needle in my liver and tell me what it looks like after I've been taking this drug? But I found out why. Do you know why this is, John?
No, I thought they were really just trying to show objective biologic kind of confirmation of improvement in disease severity. But what's the secret?
Yeah, no, you are right. But this is mandated by the FDA. So the FDA requires this as an outcome. And of course, these drugs are not a charitable organization. These drug companies, these drug companies are doing this because they want another indication. So sometimes when you look at an outcome and think, oh my God, why on earth is that the outcome? Sometimes it's because of the regulatory bodies. So for MASH, which was previously called NASH, of course, this is what the FDA expects. Otherwise, there's a 0% chance your drug will get that indication.
Oh, geez. Okay, good to know.
All right, fun facts. Anyway, keep going. Baseline characteristics, who were included?
Yeah, so from 2020 to 2023, 190 patients were randomized, and 165, so that's 87%, completed the trial, and 83% of those had a liver biopsy at the end of treatment. Most participants were white, 86%, 12% were Asian, and 36% were Hispanic or Latino. The mean age was 54, the average BMI was 36.1, 57% were women, 58% had diabetes, and 57% had stage 3 fibrosis.
All right, and what did they find?
So the primary outcome, which was the percentage of participants who met criteria for resolution of MASH without worsening fibrosis, was significantly higher in all 3 Tirzepatide groups versus placebo. Specifically, there was 10% in the placebo group compared with 44% in the Tirzepatide group 5 milligram dose, 56% in the 10 milligram dose, and 62% in the 15 milligram dose. As expected, there was a significant change in body weight. So it was about 1% in the placebo group compared with 10, 13, and 15% respectively, depending on those increasing doses of Tirzepatide. And then there was a bunch of secondary outcomes. They saw improvements in liver enzymes. So ALT, AST, GGT improved. Adverse events were similar between the two groups, and again, it was GI side effects that were most common. Discontinuation did occur in 4% of the Tirzepatide group because of those side effects. But yeah, those were kind of the main findings.
Yeah, very impressive stuff. And for a condition where we really don't have much to offer patients, before I get too excited, what were the limitations?
Yeah, it was a smaller study and a phase 2 design, so we don't have the phase 3 randomized control trial evidence per se. I guess it was a relatively short follow-up window as well. When you compare it with some of the bariatric surgery studies, they looked at outcomes over a 5-year period of time. But nonetheless, I think it was pretty impressive.
Yeah, this is very impressive, and I would bet pretty much every dollar in my bank account that when the phase 3 trials get done, they will show that this drug and probably related drugs like semaglutide are effective for MASH. Anywho, what's a take-home point?
Yeah, I think this study shows that Tirzepatide was more effective than placebo with respect to resolution of MASH without worsening fibrosis in patients with moderate to severe fibrosis at baseline. I guess not practice changing yet because we don't have the phase 3 data, but it looks very promising. And as you've already alluded to, the way that we treat this disease right now is weight loss, and we don't have anything else that we know works with any kind of meaningful improvements for patient outcomes.
Agreed. Okay, let's see if we can squeak the last one in under 23 minutes. So again, published in New England, this is 7 versus 14 days of antibiotics for patients with bloodstream infection, also known as a balance trial.
Okay, what was the question here?
For adults who are hospitalized with a bloodstream infection, excluding Staph aureus, is 7 days non-inferior to 14 days.
Very important research question. What was the study design?
So international, multi-center, but I think the only randomized trial today that wasn't industry funded, it included adults who are hospitalized either in the ward or the ICU, key exclusion, febrile neutropenia, organ or stem cell transplant, septic arthritis, endocarditis, osteomyelitis, Staph aureus bacteremia. And the key inclusion, as mentioned, is that you were hospitalized and you had a bloodstream infection. Intervention was 7 days of antibiotics, and the comparator was 14 days of antibiotics. Outcome was very clean, 90-day all-cause mortality. And I think I'll leave it at that.
Yeah, that's probably kind of the cleanest outcome we've had all episodes today too so far. All right, who's included in the study?
So 3,600 patients across 74 hospitals. Median age was 70. Half were women. 55% were in ICU at the time of randomization. 75% had community-acquired bloodstream infection. 70% of all the bloodstream infections was gram-negative bacteremia. And important to note that 20% had cancer, 30% had diabetes, and 10% were indeed immunocompromised, such as recent chemotherapy.
3,600 patients enrolled. This is massive. Okay, what were the main findings?
Yes, and these trials take a long time. This was no exception. So 10 years to complete it. So main results, 90-day mortality occurred in 14.5% in the 7-day group and 16% in the 14-day group. That's an absolute difference, suggesting a reduction in mortality if you receive 7 days of treatment, albeit with confidence intervals that include the null. The rates of C. diff were slightly lower in the 7-day group, and there was a shorter length of stay in the 7-day group by approximately 1 day total.
Okay, what are some of the limitations?
So unblinded trial, no placebo, of course, and it's primarily gram-negative bacteremia that were included.
All right, final message, take-home point, practice changing. I think it is for me. What about for you?
Yeah, I agree. 7 days should probably be the duration for the vast majority of patients with bloodstream infection that we're caring for nowadays. Before this, I think people were primarily making it up. And now we have the largest trial to date, and it aligns with 3 other smaller trials as well.
Yeah, it's so nice to see this kind of evidence in infectious disease. Like it matters. we face these questions all of the time, and so to have good data to guide our practice is really important.
Yeah, I agree. ID is like one of the worst specialties for lack of randomized trials, and primarily lots of just like making stuff up. So hopefully it'll make the life easier for the trainee as well, because there should now be a bit more consistency for how we're managing these patients. We're past 23 minutes. That's okay. John, what good stuff do you have for us?
Well, 'tis the season. So if you're able to, try to find a good organization to donate a little bit of money to, because I think a little bit goes a long way. My personal go-tos, from a Toronto fund, I love the Toronto Star Santa Claus Fund. It's just a really nice one that gets presents for kids for Christmas. And in Calgary, I like to try to donate to the Calgary Food Bank. And then Epilepsy Canada is also a very important charity near and dear.
Totally agree. I think I will share that as the good stuff today. And I think for the staff physicians who are listening to the show, you definitely have some money that you can give away. For the residents, maybe not. Anyway, John, that's it for 2024. I guess we'll We'll chat again in the new year, but yeah, great opportunity to cover some practice-changing trials from the past year.
Absolutely. See you in 2025. The Rounds Table is hosted online at medicinepods.com, your one-stop source for comprehensive internal medicine education and evidence-based medicine resources. We can also be found on all of your favorite streaming services. Follow us on X at Rounds Table.